Good afternoon, everyone. Welcome to the National Academies of Practice Webinar 301, third and final in the series to prepare for the Advocacy Day that we'll have on March 7th. With me today, we have three speakers with you in the panelists. It's Dr. Andrea Sonnenberg, Dr. Robert Pfeiffer, as well as Dr. Irma Ruplin, as well as support from Melanie Bowser from the Executive Director of the National Academy of Practice. My name is Hoyan Trung. I am co-chair of the Webinar Advocacy Training, and also note that Dr. Bob Pfeiffer is also the chair of the Hill Visit Committee that you'll hear about a little bit more. My role today is to introduce the three speakers, which I just did, and also come back to you at the end to take the question and present to the panelists. Just to remind you that in case you missed the previous webinar 101 and 201, there will be the link at the end for you to go back to review as well as viewing, and the webinar 301 today will also be recorded and make it available for you. With that being said, I will turn over to our panelists today. Welcome, Andrea.
Hi, good afternoon. Thanks for having me. So I'm going to start by giving you just a little bit of a recap of webinars 101 and 201, although we do recommend, if you haven't already seen these that cover what to expect as well as talking points, we recommend that you watch those in preparation for our Hill visit, and they are on the NAP website. The link will be given to you at the end, how to locate all of these webinars. So in recap of webinars 101 and 201, basically covering meeting the legislative aide, who is likely who you will be meeting on the Hill. First, you will introduce yourself, your name, your city, your affiliation, and which discipline you represent. As well as getting right to the purpose of your visit, because you really do only have about 15 minutes. So you're going to give a very brief description of the National Academies of Practice, and it can be brief because we are going to provide for you a document that you will leave behind. So within that document, it will explain the examples of what interprofessional practice is, that NAP is an organization that has evidence-based resources, which include not just IP and healthcare legislation and regulation, but what our functions are. NAP has a large core of expert scholars in this area, so we want to make sure that they understand that this myriad group of disciplines are available as resources, as well as NAP existing to advise governmental bodies on our healthcare system, and that we are here to serve. So today, next slide please. So today what we would like to talk to you about is why interprofessional practice is essential in terms of achieving the quadruple aim. We want to talk to you a little bit about the models of collaborative practice that have been shown to be value added and give some evidence of that. We want to describe and discuss why interprofessional education and interprofessional practice are so integrally important and interdependent, as well as the justification of interprofessional practice with regards to cost and quality of life, very much in line with the quadruple aim. We want to give you the characteristics of successful interprofessional care teams. And finally, we want to show you or help you prepare for the Hill visits. Next slide, please. So with regard to the quadruple aim, which I'm sure most of you have heard about from the Institute of Healthcare Improvement, we aim to reduce cost, and that is long-term cost savings. So that involves more efficient determination of diagnosis. It's a more precise development of treatment and intervention plans. More end results are cost savings to Medicare, Medicaid, and non-governmental health system costs. And second, to improve population health from the perspective of both health outcomes as well as improved function. So that would include, for example, based on timely diagnosis of complex patients, development of more effective treatment plans, use of the whole person, quote unquote, concept rather than the factory medicine concept that is simply symptom focused, for example. Third, we want to improve the patient experience. their quality of life. And we do that primarily based on more effective outcomes, efficiency, and shorter delays in return to productivity, as well as better sense of personal well-being. And finally, we want to improve clinician well-being or work-life balance for the healthcare workforce. This is achieved through shared accountability for quality care, as well as collaboration, which mitigates burnout and attrition. So the improved work life is aligned with the quadruple aim, and it's a national focus via the National Collaborative on Clinician Wellbeing and Resilience. Not having a good workforce for an aging population would be a concern. So none of these can be achieved without interprofessional practice, which provides the long-term cost savings. It improves outcomes and functions. It improves quality of life, and it improves the work-life balance for the healthcare workforce itself. Improved function can be added to the outcomes of quality of life as well. And I'm now going to turn this over to Bob Biefer.
The skills and knowledge that come with interprofessional practice have to be taught. There is an education process with this. And the reason why this is a specific item unto itself is that many times in medical and graduate training programs, it is not taught, and it does take some instruction to get used to a different model of practice. Basically, what many programs teach, whether it's physician or non-physician healthcare specialist, is you do your thing, you are the end all to be all, thank you very much. You take the patient, you do your thing, end of story, thank you very much, bye. And that's not what this is all about. And also at the federal level, this is not where healthcare is going. The idea of operating in a silo is something that came about by virtue in part of the HMO establishing a good foothold, and then the factory medicine, as Andrea alluded to. It was, the patient came in with a problem, you treat the problem, you dismiss the patient, end of story. And it misses a whole lot, because for patients with complex problems, for example, you really need to look at the whole person. And to be able to communicate with people of other professional backgrounds, it requires some training on how to do that. We use similar terminology sometimes, but with very different meanings, because we use it through the perspective and the vision of our own professional discipline. For audiology, one example would be auditory processing. Audiologists use this term to look at how sound is decoded by the central nervous system, starting at the brainstem and going up to the primary receiving areas in the temporal lobes. Speech-language pathology uses the same term, but with reference primarily to what happens to the information after it has arrived. For elements of receptive language. Psychology uses the same term, but with respect to how do you use this auditory input information for executive function and decision making. So communication is key, and understanding the vocabulary of other disciplines is also a very important part. There's a variety of models of interprofessional practice too. There's not just one way to do it, because depending upon the setting, the logistics, the co-location or the absence of co-location of the professionals, there are different ways to come about this to achieve the same common goal of improving quality of life, more efficient diagnoses, more precision plan or greater precision plans of intervention or treatment. It promotes the idea of best practices among team members, where you complement one another rather than simply do your thing with the boundaries that are imposed upon us by the limitations of what we do and how we do it. It's also a very important foundation for patient-centered or family-centered care. Case in point, how often do you ask a patient, what can I do for you? What is your goal that you would like to achieve after seeing me that you can't do right now? Or the family, for example. I submit for consideration. We don't do that very often, but that's an important element, because a patient needs to be a full partner in all that goes on in the decision-making process before it's all done. So a key element of our education with this is to learn how to educate the patient and the family for full partnership and decision-making. It also breaks down the silos of operation. And when you look at, for example, an entity like the Mayo Clinic or the Cleveland Clinic, they are built on the idea of communication, where you have access to information about the patient's status, what the history portends, what the prognosis is for what's going on, and how that can influence your decision-making on how to interpret your diagnostic results and your contribution to a plan of intervention. Next slide. There are different models, as I said, of interprofessional practice. The medical home is something that's really gaining traction at the federal level, where the primary care physician is the medical manager, the medical advocate, the coordinator of care, and it's like a wheel and spoke operation where the medical home is the primary care physician and the staff supporting that physician. That physician is responsible for bringing into the picture specialists to meet various needs diagnostically, to coordinate the repository of diagnostic information, and to ensure that appropriate intervention is done. Designated care teams is another element of practice, interprofessional practice. And this can be done in hospital settings, it can be done in community settings. Basically, this entails all of the healthcare providers who will be involved in the care of that particular patient. And the healthcare teams, especially if they are not co-located in a singular facility, need to be able to talk to each other, to know what's going on. I just saw patient razzle-frats the other day, and this is what I found. And I noticed that you were getting ready to introduce this kind of treatment. You need to know what I'm up to, because what I'm doing may defeat what you're trying to do, or conversely, what you're trying to do may defeat what I'm trying to do. And so it's coordination of care for the best possible outcome for the patient through these designated care teams. ACOs, Mayo Clinic, Cleveland Clinic, the Carl Clinic in Urbana, Illinois, such facilities are prime examples of accountable care organizations. And again, communication is the fundamental foundation upon which they must rest. Without the effective communication among the specialists dealing with that patient, the efficiency is lost, the quality is compromised, and the end result will not be nearly as good as what it would have been had communication been that solid foundation, so that everyone knows what everybody else is doing. The last bullet there, interprofessional care, requires ongoing effective communication between care providers regarding patient status, diagnostic findings, and treatment plans and intervention techniques. I can give you many more examples from my own experience through the years, but I'll suffice it to say that without that, the timing and the influence on healthcare decision-making can be compromised to the detriment of the patient. So communication is everything. Next slide, please. Interprofessional practice works best with patients who have difficult to determine diagnoses. In pediatrics, this is particularly important because you don't always see everything that there is to see about that child early on. We've seen many a child through here, through our center, that you look at the child, you know there's something wrong, but you can't really understand. Let's go back a slide, please. We just flip forward. You look at the child, you know there's something wrong, but that child does not neatly drop into any singular diagnostic category. And so it requires the input of many different perspectives to create a picture of that whole child And it's important to understand what are that child's abilities in addition to what are the child's needs, because you've got to leverage the abilities and really lay that as a foundation so that you complement those abilities by addressing the child's needs. The same principle applies for adults with difficult to diagnose symptoms and difficult multi-system treatment. Cancer, various types of cancer is a prime example of this, because you've got the disease itself and you have the treatment for the disease, which sometimes is almost as bad as the disease itself. And it can cause a multitude of ancillary problems that require the input of a number of different specialists in order to minimize the adverse effects. For therapy services, where you have physical therapy, occupational therapy, speech language pathology, and audiology involved, the coordination there influences what's going on, for example, for a child with balance disorder, because children with hearing loss have a much higher incidence of balance problems. They also have a difficulty with knowing where their body is in space. And so multi-system treatment is very important for a non-physician-based perspective of it all. And then the complex chronic diseases. And the two adjectives here are independent but closely related in terms of the importance of interprofessional practice. Complex, involving multiple systems, and chronic, long-term effects. When you have a chronic disorder, you can have a lot of things come from that disorder that you don't see for short-term acute disorders. And so the long-term means that there's a high probability you're going to be bringing in and involving other professionals of other professional backgrounds in order to work with you, to work with the patient, to work with the family in terms of appropriate intervention and treatment. And then you have the patients who are diagnostic dilemmas. And this can cover a multitude of different areas. It can be the patient with a form of cancer. The test results are coming back and saying there's cancer cells somewhere, but the question is, where? The child who is simply not developing motor skills, but you really can't find what the cause is. There's nothing really showing up medically or otherwise diagnostically, but this child simply is taking much longer than what you would expect to develop in a certain domain area. And so patients who are diagnostic dilemmas require the perspective, once again, the concept of the whole person for the abilities as well as the needs. And when these are communicated to the family, both of those two characteristics, abilities and needs, need to play a coinciding role in terms of describing what you found for a number of different reasons. That's another lecture for another day. But these are all characteristics of patients that do much better with an interprofessional approach than with a single professional discipline approach. And with this, I'll turn it over to Irma now at this point.
Keys, excuse me, keys to successful interprofessional practice. As we remember from the definition of interprofessional practice, interprofessional collaborative practice happens when health professionals of multiple professions work together with patients, families, and communities to provide timely and comprehensive services of the highest quality. So for this to happen, health professionals must demonstrate a strong understanding of the expertise and skills of each profession. Care team members, it is understood, are on an equivalent standing, and that there is effective and regular communications among the team members. This requires a certain degree of familiarity and respect of team members' roles and responsibilities with each other, with one another, understanding and valuing each professional's discipline and approach, recognizing that there are benefits and limitations with each scope of practice of each profession, and recognizing the complementary nature and benefits, as well as the potential for conflicts and limitations of various treatment options. And also, it requires thoughtful attention to patient and family goals, keeping the patient at the center of the collaboration in planning for care and in fostering the patient's understanding of their medical condition, as well as carefully attending to the patient's wishes and circumstances so that they can be considered in the plan of care. So it's important that for successful interprofessional collaborative practice that we have understanding of the roles and responsibilities of the various health professions, have effective communication among them, and then keep in mind that the patient is the center of our care and our planning process. Critical essentials for successful interprofessional collaborative practice is the academic and curricular support in interprofessional education programs. For all healthcare professionals, interprofessional education must be integrated and consistently reinforced throughout the curriculum, including postgraduate curriculums and training. To achieve successful interprofessional collaborative practice, students need to be prepared as collaborative ready practitioners. It has been pointed out that realistically, interprofessional collaborative practice doesn't occur by chance, but requires intentional attention for collaborative practice, for the collaborative practice process. In interprofessional programs, health professional students learn together about the various health professionals, especially specific expertise in diagnosing and treatment of certain patients. They also gain knowledge and value of teamwork skills as they practice together interprofessionally the skills required for collaborative practice. This education prepares health professional students for a professional practice that leads to more timely, comprehensive, inclusive, and leads to improved health outcomes.
All right. Thank you to our panelists. I am monitoring the box and I do not see that we currently have any questions. Are there any questions from the attendees? If you did not have the opportunity to type into the box, you can type it in now, or you can alert me. I'm double checking the box to make sure that there's no pending questions. And I still do not see any question yet. Maybe we'll give you a few seconds to type your question in case you. Well, we do have a common, wonderful presentation. Thank you. Thank you to the panelists. So seeing no further question, while in case somebody typing in the last minute, just want to remind you that we have recorded all 3 webinars, including this one today, as well as the previous 2, and they are available on the Academy website and napractice.org under the Advocacy and Advocacy Training tab. The 101 training was recorded on January 31st, and the 201 training was recorded on February 14th. And the one recorded for today will be available after the session today also. We look forward to seeing you on March 7th, Pentagon City. Today is the last day to register. Just want to remind, for those who are still contemplating, it's your last opportunity to register, not only to attend the annual meeting and forum, but also the Advocacy Hill visit.
There's one question.
We have one question, yes. The question is, are the stories you share the ones that we should be using on the Hill, or can we share our personal story? And this will go to all 3 panelists.
in my opinion, it's always more effective if you share your personal story because you were there and you experienced it. And you can be much more precise and accurate in terms of describing your own personal experiences of situations where the interprofessional aspect of the care provided, it was much, much better and made a difference in the life of that child or that adult patient.
Are there comments from other panelists?
No, I agree with Bob. A personal, poignant story is always more effective to get the point across to your audience.
Thank you. There is a follow-up question. Should the stories shared be positive or could they be negative where interprofessional care would have been better?
Jody, can you expand a little bit on what you mean by negative?
I think she's typing.
I can think of a situation where the absence of interprofessional care, where it should have been, had a negative outcome. And that's really what comes to mind right now.
I think if you cite the evidence, that makes that point even stronger. So if it's part of your personal anecdote, then that's great. And then if you could cite the evidence that shows that IP care would have been better in such a situation, that would really strengthen it.
So the comment came in, she further clarified, sure, what if the care was and the result was not optimal care for someone in the acute phase of oncology?
This is actually a fairly common scenario. I have a friend right now undergoing treatment for a pretty aggressive form of breast cancer. And she is a well-experienced individual and has started naming her own team. But I also have knowledge of other patients for whom the short-term, medium-term, and long-term care and oncological care needs to be divided into those three segments of time. The short-term care was fine. The medium care was okay, but the long-term care wasn't there. And the long-term care for a cancer patient of a serious form of cancer in particular is just as important as the short-term care, and that often involves a lot of other people from other professional backgrounds for the totality of required care for that individual. There is definitely such a thing as chemo brain that has a number of different fallout aspects associated with it. For example, that can, depending upon the age of the individual, can require the input of education, speech language pathology, psychology, just to start with, sometimes physical therapy, and on and on and on. So it needs to be tailored to the individual's specific needs, and along those three time segments, short-term, medium-term, and long-term, in order to truly meet, and the farther out you go, the greater the likelihood it needs to be interprofessional.
Thank you, Bob. There's a follow-up comment from Jody also that is mentioning, if the individual could meet the team up front, it would be helpful to the patient for follow-up care. This was someone who had pancreatic cancer. Thank you. That was a follow-up comment.
Yeah, that is very true, because when you have someone come bouncing into your room, wherever that room may be, and say, "Hi, I'm Dr. So-and-so, and I'm here to help you," and you have no clue what who this person is and what they're all about, it takes a while to really develop a trust relationship. And I speak from firsthand experience there from an illness I had a few years back. If you can meet them up front and know who they are, realizing that sometimes teams change somewhat over time depending upon what length of time we're talking about. But if you have a good idea of what all will be involved up front, that will really help to ease the process of knowing what to expect, knowing this person serves this role, and to establish a good relationship with that individual.
To the panelists, I received one more question. This one was just sent to me and not to everyone. This one is a comment and a question also. Enjoy the presentation. I'm curious if interprofessional education is IPE, why is interprofessional practice IP and not IPP?
I'll start from my own perspective and experience. A number of the terms that we use and a number of the acronyms we use vary a lot according to your background. Many times they refer to the same thing, but there's really no standardization yet in terms of some of the acronyms and terms. I've seen IPP, recently I've come across IPPC, and a lot of variations. As long as it's understood, we know what we're talking about. The functional aspect is important, but there really is no standardization yet, just depending upon what background you come from. And I'll open it up for Andrea or Irma to comment also.
I really didn't understand the question. I missed part of it. Could you mind saying it again?
Sure. The question revolving the acronym interprofessional education is IPE. How come interprofessional practice is only IP and not IPP, double P?
Oh, well, I can respond to that, and Jody could too. The IPP frequently stands for interprofessional professionalism, so there's a confusion. And I think the other thing is that IPP really needs to include collaboration, and so frequently it's IP and CP. So it's interprofessional collaborative practice, IPCP, would be another way to look at it, I guess.
I think the important thing is that when you go to speak to the stakeholders on the Hill, that you define your terms. And in the handouts that we will be providing for you to take to your visits, those terms will all be defined. So that will be, so that we're all consistent and so that all the recipients have consistent information.
All right. Thank you to panelists. Are there any additional questions? I see a comment from Jody here to say, please do not use jargon and abbreviation on the Hill. We as healthcare professionals tend to use medical jargon. So coming from her to remind all of us, do not use medical jargon and abbreviations on the Hill. Right. Are there any further questions for the panelists? Seeing no further questions, we just want to once again thank you to the panelists, and challenge all the attendees. If you have not registered yet, to please register today. That will help us with the planning, and also maybe twist the arm of a friend or colleague to register today. That will help tremendously with planning for the Hill visit, as well as for the staff to plan for the annual meeting and forum. If you have any further questions or you have for the Academy, you can always get in touch with us. You know how to email us or contact us on our website, or you can contact our Executive Director, Melanie Bowser. Seeing no further questions, are there any departing thoughts from any panelists or from Melanie before we close? Seeing no further?
No.
Well, thank you everyone again for attending, and we look forward to see you at Pentagon City on March the 7th. Safe travels.
Thank you.